I'm a MMC graduate from 1967, and I currently live in Southern California. I stopped operating about 3 years ago, and even now I'm involved in resident education and teaching. Badri approached me a few months ago and suggested that I speak to our group on a topic that would be of interest to us all. So I thought about this for a while, and I decided to talk about falls in the elderly and the resulting injuries to the brain and spine. I chose this topic because of its extreme frequency, to the point I think almost all of us might know of a friend or relative who in his or her older age sustained an injury from a fall that dramatically changed the course of his or her life. So this topic is rather mundane. It is certainly not as exciting as some of the other talks we have heard, like genomics of coronavirus and vaccines and things like that. And in fact, there may be nothing new in this talk. It may simply be a review of the topic. It is going to be presented in a rather light-hearted manner. As I know, it is almost 9 o'clock in Madras, and you can all take it easy, relax, and sip your wine or whatever drink you have in your hand, and just follow me along. And I think the talk will probably be for about 45 minutes. Let me, first of all, in terms of disclosures, I don't have any disclosure at this time. I have no financial conflicts. Some of the slides are borrowed from stock, and these are in the public domain, so I don't need any permission to show them. The clinical cases that I'll be showing, some of them are my own. The following will be the outline of this talk. We'll talk about why older, by older I mean patients over the age of 65, they fall. And then we'll talk about the type of resulting neurological injuries. I'll provide a brief literature review, especially two salient articles that give a lot of important statistics on this topic. We'll talk a little bit about brain injuries. Subdural hematoma is probably the most common injury that is sustained in the head following a fall. So we'll talk about that a little bit more in detail. We'll say a few things about spinal injuries. And finally, we'll touch upon fall prevention strategies and whether they work. I think I have something like about 33 or 34 slides, and I hope to get this done in about 40 or 45 minutes. So let's start with a typical scenario, and then we can work backwards. So let's imagine a generic case of a 75-year-old male, fairly healthy and active, who goes to visit his son out of town. After dinner and some drinks, he goes to bed. He wakes up at 2 o'clock in the morning to pass urine, and he has some urgency. He rushes along. The hallway is dark, unfamiliar, and he turns the wrong way and falls downstairs. He gets up and feels all right, but by the morning is covered in bruises and is a bit drowsy. The family take him to the local emergency room, and he has a CAT scan of the head and is found to have a subdural hematoma. It is now also revealed that he is on warfarin or Coumadin for atrial fibrillation prophylaxis, and his INR, international normalized ratio, is 5, or at least 2.5 times what it should be. So where do we go from here? Now, I cannot tell you the number of times I have faced with this situation over my 50-year career. I've kind of always worked at trauma centers, taken call, and this kind of scenario is very typical. So we now have a complex situation for a slightly older individual who has a subdural hematoma and is also anticoagulated. He needs surgery, so we have to reverse the anticoagulation. If we can use the 4-factor PCC if that's available. If not, we have to use fresh frozen plasma, vitamin K, things like that. But the fact is that sooner or later, we have to operate on him, and we have to face the bleeding and face the anticoagulant situation. So he has surgery. He does not promptly recover. He has a seizure in the postoperative period. He has always had some prostate issues. He now has a catheter that cannot be removed, and some infections follow. He then gets a DVT, has to have an inferior vena cava filter, but he cannot be started back on his warfarin because the subdural hematoma surgery is still fresh. So this goes on, and he has more complications, and the poor man finally ends up in a rehab unit, and 3 months later he is either returned home in a poor condition or ends up in a nursing home. Now, the tragedy of this is this 75-year-old was really in good health and fully functional, and this accident happened in a second and totally changed his life. So it's not like an older person having a disease where for months and years he is gradually getting worse. This is something that happens suddenly, dramatically, changes his life and also his family's life. And finally, both the patient and the family feel somewhat cheated that this accident needed to happen. And they have a guilt feeling, well, what could have been done to prevent this? So we can now go back and in the rest of the talk, we can analyze this situation. So the pathology of trauma is like the pathology of many other diseases in that it depends on age. For example, the type of trauma a child has is very different from the type of trauma an elderly person will have. Mechanism is important. Today, we're going to talk mostly about falls through a patient's own height or from a small stool or falling downstairs or something like that. We're not going to talk about the major car accidents or multiple trauma. So these are all low velocity injuries. That is what we're going to talk about today. Now, the organ involved is important. And today we're going to talk about the brain, the spine, and the spinal cord. But in a low velocity injury, you can have damage to any organ, including fractured ribs, lung contusion, contusion of the liver, or many long bone fractures. Comorbid factors, especially in the elderly, are very important, and these include obesity, diabetes, hypertension, and especially osteoporosis, which can lead to many fractures. A little bit of information about some basic statistics. That is, depending on the country you live in, about 8 to 15% of the population is either 65 years or older. If you look at many of the traumatic brain injury admissions in a hospital, you find that roughly about 80% occur in the elderly and about 30% in the younger patient. Then there is the increasing use of prophylactic antithrombotic agents for various things like atrial fibrillation or DVT, and almost 50% of the elderly patients are taking some kind of an antithrombotic agent. And later we have a couple of slides to discuss this in a bit more detail. Now, what are the factors that predispose to falls in the elderly? These can be classified as personal and environmental. I have listed them here and you can read them yourself. But in a multivariate analysis, the important ones that have been found to cause falls in the elderly are visual problems, poor vision, and cognitive impairment. Let's talk a little bit about this. Elderly patients have decreased vision for many reasons. It could be cataract, or it could be post-cataract surgery with some loss of vision, glaucoma, or it could be macular degeneration. But very often, it is simply laziness on the part of the person to pick up his glasses and wear them. The glasses could have been misplaced or temporarily lost, or the person in the middle of the night when he gets up just does not bother to wear the glasses and proceeds to the bathroom, and his vision is blurred, which results in many of these accidents. Although poor strength and muscle weakness is well known in the elderly, it is really balance that is the most important. So the older patients have decreased balance. Now, balance and motor strength go hand in hand, but it is the balance that really causes the falls. Many of the older patients may have cognitive impairment, which may simply be some decreased memory, or some of them may have frank dementia. And if you have frank dementia, then surely there are more reasons for you to fall. Medications are also important. Elderly patients are on many medications, including sleep medications or anxiolytics. And all this, especially in the middle of the night, can cause some confusion and may result in a fall. Alcohol may be a contributing factor. Environmental factors. Once again, these are listed. I'll just touch upon a couple of them that have been found important in a multivariate analysis. And the first is unfamiliar surroundings. So an elderly person gets up in the middle of the night in a new house or in a hotel room, and then for a couple of seconds, he or she is a bit confused. They don't know where they are and which way the bathroom is. So unfamiliar surroundings is a very important cause of falls in the elderly. Then the rest of it, you can go through the list. I'll just mention the falls in ice and snow. Now, in the colder countries, in winter months, the parking lots are rarely cleared well. There's always ice. You may not even see them. And there is hardly anyone I know of, including myself, who has not slipped and fallen on a sheet of ice. So you don't even have to be elderly. Anybody can fall, but especially the elderly with some decreased balance can slip and fall in ice, and this is a very common cause. Falls from bicycles are also common, and I would like to jokingly state that if you are 75 years old and if you have not ridden a bicycle for 60 years and you are giving your grandchild a bicycle for a birthday present, then surely don't try it yourself. You'll just end up with a bandage on your head. There are also kitchen accidents. I'm not going to address them, but older patients cooking is another dangerous thing, and many of them sustain burns and scalding injuries due to tremors or the phone ringing in the middle of cooking something and the person forgetting that there is something in the stove. But so these are many of the environmental factors. I'm going to quote one study now. The study was published in the New England Journal of Medicine. I have 2 or 3 slides about this study. The study uses an acronym called STRIDE, and that is Strategies to Reduce Injuries and Develop Confidence in Elders. It is a randomized study, and the primary aim of the study is to find out whether fall prevention programs are meaningful and reduce the incidence of these injuries. We'll go to the study itself now. So it was published in the New England Journal last year. It was done from 2014 to 19. It's from Boston, from many of the primary care practices in that area. And they had two groups, a control group versus an intervention group to prevent falls. And they looked at modifiable risk factors for falls. This includes impairment of strength, gait, or balance, certain medications, postural hypotension, problems with feet or footwear, vision impairment, osteoporosis, and home safety hazards. So they had a protocol-driven recommendation for management of these risk factors, in that nurses and healthcare professionals were assigned to go to the index patients' homes and talk to them, educate them, and modify their environmental factors and see how effective this was in preventing the falls. The primary outcome was the first serious fall or injury, the secondary outcome being the first patient-reported fall. This is another problem in that the older patients, if they have brief falls, they won't even report it. Here are some numbers. So the total cohort was 18,571 patients, and 5,451 met all the criteria. So it's a large study. The mean age was 80, all over 70 years, and it was a 4-year trial period, and that gave us at least a minimum of 1-year follow-up. So almost 38.9% had a fall with an injury in the previous year, and about 35% had more than one fall. Now, on a multivariate analysis, although all the factors I have mentioned before were considered, only 3 things really bore out, and that is strength and balance, osteoporosis, and vision impairment. So it's worth remembering that these 3 have been found to be the most important factors in contributing to a fall and the injury sustained. For example, osteoporosis does not contribute to the fall, but results in greater injuries. So there is also an incidence of death, and that is 3.3 per 100 person years. But a literature review shows that it could be as much as 5 to 14 per 100 person years. The rate of hospitalization is also high, 32.8. But this study finally turned out to be negative in that they could not reduce the incidence of falls between the control group and the index group, in spite of these nurses going to their homes and changing their environment and things like that. The reason is really lack of compliance on the part of patients, failure to change risk factors, and reluctance to change medications and other health factors. So the study finally ended up being negative in that they felt that they could not reduce the incidence of falls in the elderly, even with active intervention. Now we'll switch gears a little bit and let's talk about some of the changes in the brain in the elderly. So if we look at the top slide, we have an MRI scan of a 25-year-old. It shows a head full of brain. There is hardly any atrophy. Now here on the right side, there is an MRI of the brain of a 75-year-old, and you can already see that there is frontal atrophy, there is a collection of CSF, there is sulcal prominence, and you can see in the white matter there is a lot of microvascular ischemic changes, that the white matter looks rather dense. As we grow older, the brain tends to shrink, but the skull remains the same. And therefore, there is a certain amount of craniocerebral disproportion. That means the brain is simply hanging from the skull, and the subdural space is enlarged and may be filled with CSF. The bridging veins that go from the surface of the brain into the sinus then become stretched, and one can almost imagine the brain hanging from the dura by these bridging veins ready to snap. The CSF volume also increases, the ventricles are larger, and the subarachnoid spaces also increase, and there are white matter changes due to microvascular ischemia. Now I'm going to digress one more time and talk about the role of antithrombotic agents, because this, especially in the elderly, is so important in deciding the morbidity and mortality. As I mentioned before, almost 50% of elderly patients are taking some kind of antithrombotic agents for stroke prophylaxis, cardiac prophylaxis, or atrial fibrillation. This is another landmark study published in August of 2020, and the total cohort is 1,365 patients, all elderly, and about half of them were on antithrombotics and 641 were not. Now, in the antithrombotic group, I also include the aspirin group, which is the commonest. So 413 out of the 724 patients were on 81 milligrams of aspirin. Now, you can see the rest of the big breakdown here, but the important groups are the groups on warfarin. About a quarter is on warfarin or Coumadin, a significant anticoagulant. Then about 59 on the direct oral anticoagulant, that is dabigatran or apixaban. As you know, these patients don't require their blood monitored as much as the warfarin group. Then 48 on dual antiplatelet therapy, that is aspirin and Plavix or clopidogrel, and a smaller group on both antiplatelet and anticoagulant, and another small group on antiplatelet and direct oral anticoagulant. So for a second, we can really forget about this 81 milligram per day aspirin group. I'll mention one or two things about that later on. But the main emphasis is on patients who are on warfarin or Coumadin, or who are on dual antiplatelet therapy. So the mean age here was about 79. Most of them fell from their own height. Now, just a couple of words about a person falling through his or her own weight, her own height. So let's assume that an average person is somewhere between 5 foot 8 inches and 6 feet tall. And when this person falls back, he falls, the head weighs about 20 pounds. So you can imagine a weight of 20 pounds really falling through a height of about 5 foot 8 inches to 6 feet. So it is a significant fall for the head for a person to fall through his own height. The incidence of intracranial hemorrhage is almost 50% in the antithrombotic group and 32.5% in the non-antithrombotic group. Even more important, patients on warfarin had progression of their intracranial hemorrhage after admission in 21.6%. So after the fall, the injury is not severe. They come to the emergency room, have a CAT scan. They are found to have either a small hemorrhage or a small subdural hematoma, but then about a fifth of them will progress during the next 24 or 48 hours, and the blood clot will become significant, compared to the non-antithrombotic group, where it is only about half as much. Also, the overall outcome is worse in the antithrombotic group, and the overall mortality is about twice compared to the non-antithrombotic group. Now, in a multivariate analysis, A single antiplatelet therapy, such as aspirin 81 milligram, was not significantly associated with mortality or morbidity. What we have to watch for is the dual antiplatelet therapy, that is aspirin and Plavix, or especially warfarin. The worst group was the group where both antiplatelet therapy such as aspirin and or Plavix was combined with warfarin, and this is understandable. Patients taking the direct oral anticoagulant such as dabigatran or Eliquis, apixaban, they fared better than warfarin group. Now, I would like to say a couple of words about my personal experience with these antithrombotic agents. Now, as a neurosurgeon, I rarely, if ever, prescribe antithrombotic agents myself. These, as you know, are prescribed by internists and cardiologists and cardiac surgeons, and they are prescribed for a variety of reasons. Commonest perhaps is suspected TIA, or it could be atrial fibrillation. Atrial fibrillation is probably the commonest cause for prescribing warfarin, or somebody could have a mechanical heart valve, such as an aortic valve, and they may be getting warfarin to prevent complications of a mechanical heart valve. Now, as a neurosurgeon, I am at the receiving end of patients with antithrombotic agents. So they come to me after the fall or after the injury, and I'm faced with a CAT scan that shows some blood, and these patients are on these types of therapy before they came to me. I think the internists and cardiologists, they prescribe these medications, but they are not at the receiving end of the complications. My humble request to the internists and cardiologists is that when they are prescribing these drugs, especially as prophylaxis, they absolutely must educate the patients about the danger of these drugs and how important it is to have follow-up. For example, if you're going to be placed on warfarin, then at least once a month, you need to go and have your prothrombin time done and the INR calculated and the dose adjusted accordingly. If you find that a patient is not very educated or not very compliant, then perhaps it is not such a good idea to use warfarin for prophylaxis, because sooner or later, these patients will end up in the emergency room with some kind of bad bleed somewhere. So this is something that in my practice I used to be faced with all the time, that in the middle of the night, we'll have somebody on these agents and we had to reverse them. It's not always easy to reverse them. Some of the reversal agents are not very effective, and yet because of the urgency of the situation, we cannot wait and we have to operate, and sometimes that leads to bad outcome. A couple of words about brain injuries. As I told you, we're not going to talk about major brain injuries from car accidents or anything like that. We're going to talk a little bit about the Coup and Contracoup injuries and the resulting brain contusions, which will be in the next slide. In this slide, you see an example of a traumatic subarachnoid hemorrhage, which you can sometimes have from a fall. And here you can see the subarachnoid spaces of the brain in a CAT scan filled with blood. Or occasionally, you can have an intracerebral hemorrhage, like what you see here in the thalamus. The only thing is, when you see a hemorrhage like this, you don't know whether the person had a stroke and fell, or whether he fell and had a stroke. And very often it is the former. The patient had a hypertensive hemorrhagic stroke and fell as a result. I want to spend a couple of seconds on this concept of Coup and Contracoup injury, because this is probably the commonest mechanism for a brain injury. So if a person slips on ice and falls backwards, what he does is he lands on the occiput of his head. And the surface injury on the occiput, which results in a scalp laceration or a scalp fracture, is known as the Coup injury. Now, at body temperature, the brain is not like the liver. It's not really a solid organ. At body temperature, the brain is softer. It's more like jello. Therefore, when a person falls on the back of the head, the brain inside shifts forwards. And if you look at the base of the skull, there are a lot of irregularities and sharp prominences like the lesser ring of the sphenoid. And the brain that is sliding on this rough surface in the base of the skull lacerates the brain and causes traumatic contusions and hemorrhage inside the brain. And this is referred to as the Contracoup injury. So the Coup injury is a surface injury, not so serious because it is mainly of the scalp and the skull, but it needs to give you a clue that there could be a serious Contracoup injury at a site diametrically opposite, namely not the occipital area, but the frontal area, as this slide here shows. So this is an important concept when patients fall through their own height and land on the back of their head, which happens for a variety of reasons. I'm sorry for a couple of gory slides, but I want to show you a case example. So this is an 80-year-old female who fell out of bed. She was on warfarin. Her INR was very high, and in a short period of time, she rapidly lost consciousness and came to the emergency room unconscious with a dilated pupil and a hemiparesis due to herniation. And here on the CAT scan, you can see that the brain is squashed by bilateral subdural collections. This is a fresh subdural hematoma because she's lying on her back on the CAT scan, and you can see the blood layering just like in a test tube. Here is serum and here is SPAC cells with a straight line. And that's what tells you that this is a fresh subdural hematoma where the patient is still bleeding. And the blood is not clotting, but is layering because of the presence of anticoagulants. I'm going to go to the next slide and then come back to this slide. So here are the rest of the scans. And if you look at all the slices, you can see that this goes up all the way. In multiple scans, you can see the hemorrhage, the falx is shifted, the brain is compressed, and there is active bleeding inside the subdural hematoma. So this patient then has a craniotomy, as you can see here. The dura has been opened. This is the blood clot inside, fresh blood, not even clotted. And meanwhile, you are also trying to reverse the warfarin. We usually use the 4-factor prothrombin complex concentrate, which is the most effective. But sometimes, in spite of that, you can have some increased intraoperative bleeding. And there are certain strategies that we use for that, which I'm not going to bother you with just now. What is interesting is, after you have removed this blood clot, you find that the brain underneath is almost pristine. There is no evidence of brain injury because this hemorrhage occurred due to tearing of one of the veins that I talked about, and the blood simply poured into the subdural space. The brain itself was not damaged at the time of injury. So if you can quickly address this and remove the blood clot that is pressing on the brain, you can expect the patient to have a good recovery because there is no underlying brain injury itself. The clinical manifestations are due to brain compression by the large hemorrhage. And this diagram shows that herniation where the temporal lobe is pushed through the tentorial hiatus and is compressing the brainstem. So this is the scenario with an acute subdural hematoma in a patient with a fall through his or own height. And I think it almost always occurs in a setting of antithrombotic agents, especially warfarin and anticoagulation. When these patients come in, I have always found that they have not been compliant. Many of them have not had a prothrombin time or INR done for many months, if not even years, and their INR is unusually high. Now, the chronic subdural hematoma is much more common in the elderly, and sometimes it can occur as a result of very minimal trauma that the patient may not even remember. It could be something as minor as hitting your head on a windowsill or hitting your head on a door frame while getting into the car. Sometimes in some elderly patients, this could also be multiple repeated injuries. And once again, it occurs because a vein in the brain tore and there was some bleeding, and the blood is hyperosmotic. It absorbs the CSF. And unlike the previous case of an acute subdural hematoma, you see here this hypodense collection, which is typical of a chronic subdural hematoma. It is also causing brain compression. If you look at the symptoms, they are very different from an acute subdural hematoma. Here, the symptoms are gradual and progressive. It is headaches, maybe some slight weakness, some confusion, occasionally seizures, and some cognitive impairment. On occasions, I've had family members see these patients and think that they are having progressive dementia, such as Alzheimer's. Occasionally, unfortunately, these patients are even admitted to a nursing home with a diagnosis of dementia or Alzheimer's. And finally, somebody gets a CAT scan, and then you find that they really have bilateral subdural hematoma causing brain compression, a rather curable entity. Sometimes inside these chronic subdural hematomas, you can get acute hemorrhages such as this. And here you can see during a craniotomy, the dura is tense and bulging with a hematoma underneath. And when you make a small incision in the dura, this dark crankcase oil type of material oozes out. Once again, if these patients are diagnosed fairly quickly, this is a recoverable situation and the patients can make a good recovery. There are also many complications these patients can have, which unfortunately can lead to morbidity and mortality. And these are listed here, but the commonest is seizures. About 15% of patients who have subdural hematomas can have seizures. And the problem with seizures is that during the seizure, a second injury can occur, or the patient can have a post-ictal paralysis, and even worse, they would require long-term anticonvulsants. And elderly patients don't do well with long-term anticonvulsants, and it tends to cause cognitive impairment. We'll move on now to some injuries to the spine and spinal cord. So as we get older, just like every other organ in the body, there is also some degeneration of the spine. This is referred to as spondylosis. This is how it happens. So if you look at this scan here, which I'll be showing you later on as well, this is the sagittal or the lateral view of a cervical spine MRI in an older patient. Here is C2, and the disc between C2 and C3 is okay, but from C3 to C4, C4 to C5, and C5 to C6, and also from C6 to C7, you see that there is multi-level disc degeneration. So if you look at an intervertebral disc, as you might recall, It has the outer annulus fibrosus, which contains the central nucleus pulposus, which is under a certain amount of pressure. The nucleus pulposus is almost 80% water. The discs are avascular tissues. They get their oxygen and nutrition through a very complex process of diffusion, which comes from the end plates. So as a person gets older, especially in smokers, this microcirculation that provides nutrition to the disc is lost and the disc becomes dehydrated. Further, as I mentioned before, the head weighs about 20 pounds. So for 75 years or so of this person's life, this spine has constantly borne the weight of about 20 pounds. And that also causes the discs to degenerate. And when the discs degenerate, the end plates start rubbing against each other. You get osteophyte formation. You get reduction in the height. And this is why older patients lose 2 or 3 centimeters in their height as they age. All this would result also in some ligamentous changes in the back of the spine. The ligaments become rigid, they buckle, and together all these factors cause cervical spine canal stenosis. So if you look at this MRI here, the spinal cord above C3 is nice and normal. It is bathed in CSF, which is the white that you see here. Again, below CSF, below C7, the spinal cord is normal and has got CSF on either side. But between C3 and C7, you can see there is hardly any CSF. The spinal cord is compressed and looks unhappy. Here is a stock diagram that shows the changes in a diagrammatic fashion. You can see that the spinal cord is edematous inside due to these changes. And this is the diagram showing what can happen after surgery when you remove these discs and do fusion and correction. This doesn't always happen, but can happen. So cervical spondylosis is very common in the older patients. And when the spinal cord is compressed like that, it can either cause myelopathy, that means spinal cord dysfunction, which is an upper motor neuron lesion, or radiculopathy, which is compression of the nerve roots, which can cause radiating pain in the upper limbs. That is a lower motor neuron type of injury. Occasionally, it can cause a combination of both myelopathy and radiculopathy, and sometimes that may be mistaken for ALS or motor neuron disease. Another common spine injury is osteoporotic compression fracture. Osteoporosis is especially common in elderly white females, and sometimes even spontaneous fractures can occur, like what you see here of the L1 vertebra. This is what is called a bow tie deformity. And here the bone has become so weakened that the disc has become stronger than the bone, and the end plate has collapsed, and you get this typical bow tie deformity, compression fracture, and this is typical of osteoporosis. You can see a similar phenomenon beginning to occur here as well. You can also have spinal fractures, usually once again due to a fall downstairs or from a height. Pain is the main symptom. This is an extreme example that I picked up from a nursing home of a patient with dementia who was falling repeatedly. He was cognitively too impaired to complain about anything, but the nurses found that he was holding his neck in a peculiar position, and they got this x-ray. And you can see that there is a marked subluxation here between 5 and 6. When this trauma happened, nobody knows because he has had so many falls. This, of course, requires surgical intervention for correction. Another thing that happens to the cervical spine in the elderly is spondyloarthropathy. There are many examples of this. This is an example of ankylosing spondylitis. So in ankylosing spondylitis, the ligaments calcify, the spine becomes fused like a long bone, but the bony texture of the spine is inherently weak. It is more susceptible for trauma. And you can see the calcified ligaments here, and they have a typical injury called a transdiscal fracture, where the fracture occurs through the disc space, which is fused. Another common fracture in the elderly when they fall on the back of their head is an odontoid fracture. Here is C2. This is the odontoid process, and you can see that there is a fracture through the base of the odontoid process. This can be treated in many different ways. In this particular instance, it was done with what is called a lag screw from the front. I'm going to spend a little bit of time with this entity called central cord syndrome because it is so common. I would say that in the elderly, this is perhaps the commonest type of C-spine injury that I would see. What happens here is an elderly patient falls on their face, and the telltale sign is here. They have a laceration in the forehead, bilateral orbital contusions, and facial injuries. So when you see this in an elderly patient, she's already in a neck brace, you should immediately think about what this is going to do to the spinal cord. Because the older patients have what I have already shown you, cervical spondylosis, and they have when they have an extension injury, they have what is called a central cord syndrome. And here the symptoms are marked paralysis of the upper limb, especially the hand, with involvement of the bladder. The legs are usually spare. The reason for this is that if you look at a cross-section of the spinal cord, here is a pyramidal tract, and the hand fibers are located medially. And when you have a hemorrhage that starts in the middle, the hand fibers are affected first, and that causes the weakness of the hand. Now, why do you get a hemorrhage in the middle of the spinal cord? This is an autopsy specimen of a spinal cord from C5 that again shows this hemorrhage in the middle of the spinal cord. On this MRI scan, if you look carefully, you can see that there is an abnormal signal here in the middle of the spinal cord. Now, this autopsy is not from this patient. This is from somebody else, but the pathology is obvious. The reason this happens is that the spinal cord has a rather peculiar blood supply in that it is supplied by arteries that are circumferential in the periphery with perforating arteries that go towards the middle. So when the spinal cord is compressed, the maximal pathology and the ischemia occurs at the tips of these penetrating blood vessels, and you get a hemorrhagic infarction, and that's what causes this thing called central cord syndrome. It's not a good thing to have, and recovery is often rather slow. So let's move on. So the minute we see a patient who has a brain injury from a fall or whatever, the question that is foremost for the patient and the family is what's going to happen to this person. One of my mentors used to say that it is never a good thing to have a brain injury. He used to tell me it's like dropping an expensive watch. It never runs quite the same again. Well, we have certain things that we can go by to tell the family how this person is likely to go. So this is a crystal ball. The crystal ball is the prognosis. So what are the factors? The most important is age. Again and again, any number of studies have shown that age is so important in prognosis of brain injuries that almost every decade matters. That's why children do so much better than adults. Over the age of 65, a brain injury is not good news. So this is why it is important to prevent this in the elderly. The other factors are what's called Glasgow Coma Scale, which is 3 to 15 score based on eye-opening, best motor exam, and best sensory. But this is not that important for low velocity injuries. It is more important for major car accidents. Level of consciousness. If a person is unconscious, obviously it is not so good. CT scan. The worse the CT scan, the worse the prognosis. We already talked about the deleterious effects of anticoagulants. Now, there is one thing I'm going to mention, which you may not be familiar with, and this is becoming an increasingly important factor, at least in the Western societies, and that is elderly patients living alone. This is a bad prognostic factor for every injury and every disease. Patients who live alone cannot be sent home after any type of major surgery or illness because they cannot take care of themselves. And home care does not provide that good a care as one would expect. Living alone is a very important bad prognostic factor for everything, including brain injuries. And many patients with head injuries who could have gone home if they had a good family end up in a nursing home just because they don't have a home to go to. Some factors about, we're coming to the end, so maybe another 5 minutes or so. So some factors about fall prevention. Now, it is a cliche to say that an ounce of prevention is better than a pound of cure, but nothing is more true about this than falls in the elderly. As much as possible, these should be prevented. So what are some things you can do? We already saw that the three most important factors were strength and balance, vision, and osteoporosis. So some of this can be addressed. A certain amount of regular exercise, something as simple as walking daily, may improve strength, endurance, and balance. Don't forget balance. Elderly patients fall not because they are so weak, but because their balance is not good. And why the balance is not good? It is a combination of motor strength and visual impairment. So balance is a product of strength and vision. You need vision for proper balance. Vision is affected for many reasons in the elderly, and some are easily correctable, such as cataracts. But sometimes it can also be due to personal negligence, like not bothering to wear the correct glasses, or misplacing them, or not wearing them at all. This is also true to a certain extent with hearing. There are many elderly patients who could do significantly better with hearing, especially when they are crossing a street, but they are lazy and will not either wear their hearing aid or would misplace them or might feel embarrassed to wear a hearing aid. Medication management, when possible, should be resorted to, especially with regard to warfarin therapy, and if possible, that should be converted to a direct oral anticoagulant, especially if the patient is not very compliant. Constant reiteration by the family is very important. So if you're living with a family, the family members can constantly tell, usually it's male, I'm sorry to say, look, don't climb here, don't do this, don't do that. And that's important. Who has not climbed on a soft cushioned chair to change a light bulb? Now, that is, of course, a very bad thing. And if you have a wife, she would tell you, look, don't do that, because if you fall and break your head or something, I'm going to send you to your mother. So that could be something that could be scary enough. So family involvement and supervision is very important. There are some patients who fall all the time, and unfortunately, if that is the case, it will be very difficult to take care of them at home, and they'll end up going to a nursing home requiring care round the clock. Finally, did we learn anything today? So falls can be accidents or incidents. Accidents, of course, we cannot do anything. Incidents can be prevented, and we should. And I gave you many examples of preventing incidents, especially getting up at night to go to the bathroom. You need to make sure your pathway is clear. You need to have a night lamp, and you need to wait for a couple of minutes when you sit in the bed to make sure you get your bearings before you start marching down the hallway. Beware of antithrombotics. Living alone is a risk factor. Now, in the US, there is a store called Pottery Barn that sells a lot of ceramics and glassware. And on the shelves, they have a sign that says, if you break it, you own it. This is true for us too. Older patients, even if we live with a partner, if you fall down and break something, you're going to put a lot of pressure on your elderly partner to take care of you. And the marriage could break from this. Your elderly partner may not be able to take care of you when you're broken. So please remember that if you get broke, that you own it, and be responsible and be careful about riding bicycles that you haven't ridden for 60 years, or climbing ladders on a wet day, or starting something without thinking about the consequences. As they say, there is no fool like an old fool. So you should listen to your family, and when they tell you don't climb here or don't do that, please do listen. I want to now spend a couple of minutes, especially since we have the dean in our presence, about our medical school and our hospital. I cannot thank enough for the kind of education we received at Madras Medical College and Government General Hospital. Starting from Dr. Cooper, Dr. Anandan, Dr. Nayan Verghese in the first year, all the way to Dr. Atmarama Rao, Ratnavelu Subramaniam, K. Ramachandra, M.K. Krishnamenan at the obstetrics hospital. We have had such fantastic education. And if I remember correctly, I think we paid something like 250 rupees a year as fees, which I think is something like $4 or $5 today. We are so fortunate. We had such fantastic teachers. I think of them all the time. Now, since the dean is a pediatrician, let me also tell him that we were so fortunate to be educated by none other than the famous Dr. Achar. I have been on rounds with Dr. Achar and Dr. Balagopal Raju. And in fact, I have heard Dr. Achar talk to us about Indian childhood cirrhosis and how he used to treat it with peanuts and things like that. These lectures are always in our mind, and we just cannot thank our hospital and the medical school for having received the best education in our lifetime. This is unparalleled, and nowhere in the world can you get this type of education. Now, I was a very fortunate apprentice. I managed to find this photograph. This was taken, I think, by myself in an Instamatic camera in 1964 or 65 upon the inauguration of the head injury ward. If you remember, Dr. Kalyanaraman, this is Dr. B. Ramamurthy, this is Dr. Balasubramaniam. These were the three great neurosurgeons of General Hospital, and they had the vision to start a head injury unit in 1964 or 65 in the old General Hospital on one of the upper floors. And I used to go there and spend some time, and I had some cheap camera where I managed to take this photograph. At that time, I didn't realize the value of it. But now, almost 55 years later, I look at it with such love. These three people, Dr. Kalyana Raman, Dr. Balasubramaniam, Dr. Ramamurthy and Balasubramaniam, induced in me a lifelong passion for the nervous system. They had more in their fingernails than I have in my head. I would never know what they knew. And unfortunately, these two are no more, but Dr. SKR is still around. And I owe him so much to where I am today. And finally, I've got to come back and I have to thank Badri. I mean, words cannot describe what he has done to our Alumni Association, for setting up the website, for coming up with the name Madras Red Fort Doctors Association. He has been a one-man army, and I really cannot thank him enough for all that he has done. Finally, this is a view of where I live today. This is a small beachside town called Carlsbad. It is just north of San Diego and about 25 miles from the Mexican border. And if you happen to come to Southern California, please let me know so that we can entertain you. Badri has been here, and it's a kind of a quiet, peaceful place. That's all I have to say just now. And once again, thank you so much for giving me this opportunity to address you all, especially the Dean of Madras Medical College. I'm so honored that he could join us and listen to this talk. Thank you.